Pituitary adenoma. So we'll review the background, clinical presentation, classification, and discuss about radiotherapy, benefits of gamma knife gel management, and complications. So pituitary is a 60 milligram midline structure in sella turcica bordered by diaphragm ocella, tuberculum celli, dorsum celli, and lateral sinuses and sphenoidal sinuses, anterior posterior lobes. Function: anterior lobe FSH, LH, ACTH, TSH, prolactin, growth hormone production, posterior lobe ADH and oxytocin. Etiology is unknown, not associated with environmental factors. 10 to 15% of the primary brain tumors, 20 to 50% of the pituitary glands at autopsy found to have adenomas. 70% of adenomas are endocrinologically secreting. 25% of those MEN when developing pituitary adenomas. Pituitary adenomas have long natural history, vary in size and direction of the spread. Microadenomas less than 10 mm, macroadenomas less than more than 10 mm can cause problems due to mass effect. Clinical presentation: most common are endocrine abnormalities, hyper or hypersecretion of the anterior pituitary hormones, headache, vision changes, bitemporal hemianopsia, and superior temporal defects. Endocrine active pituitary adenomas can produce prolactin, which can cause amenorrhea, galactorrhea, impotence, growth hormone, gigantism, and acromegaly. Corticotropin production produces Cushing's disease, Nelson syndrome, post-adrenalectomy, and TSH hyperthyroidism. Non-functioning adenomas: 20 to 30% of the patients do not have the classical hypersecretion syndromes, may grow to a large size before they are detected, present due to mass effect, visual symptoms, headache, and hormonal deficiency. Evaluation is done by MRI, visual field assessment, endocrine evaluation, tests of normal gonadal, thyroid, and adrenal function, radioimmunoassays for hormone levels. Classification: imaging, surgical classification, clinical and endocrine, functional or non-functional. Pathological classification: WHO classification reconciles with the three symptoms. So, in one classification, there is microadenoma grade 0 to 1, macroadenomas 2 to 4, grade 0 intrapituitary microadenoma with normal cellular appearance, grade 1 animal sized cella with normal sized cella with asymmetric flow, grade 2 enlarged cella with intact floor, grade 3 localized erosion of the cellular floor, grade 4 diffuse destruction of the floor. Classification: tumor bulges into the chiasmatic cistern. Type B, the tumor reaches the floor of the third ventricle. Type C, the tumor is more voluminous with extension into third ventricle up to foramen of Monro. And type D, the tumor extends into temporal or frontal fossa. Pathological classification: benign or malignant, chromophobes or non-functioning, basophilic, Cushing's, acidophilic, acromegaly, and WHO classification is 5-tiered system. Clinical presentation and secretory activity, size and invasiveness, histology, typical or atypical, immunohistological profile, and ultrastructural subtype. Long-term effect of efficacy of the conservative surgery and radiotherapy and control of pituitary adenomas should be assessed. And the extent of the surgical resection did not correlate with the outcome, and the patients had assumed radiation-induced visual deterioration, and there is a risk of second brain tumor. High tumor control rate and low toxicity in non-functional pituitary adenomas, suggesting that the limited surgical approach and post-surgical conventional fractionated external beam radiotherapy should be treatment of choice. Radiation therapy: the overall survival after the treatment for all the patients is not significantly different from the age, sex, and race matched population. Patients receiving surgery and post-operative radiotherapy had a greater control of the local disease. External beam radiotherapy salvage of the surgical failures is possible. External beam radiotherapy treatment results in low complication rate. Gamma knife radiosurgery: tumor control, tumor shrinkage, endocrinological improvement, and endocrinological normalization. Tumor growth control results achieved with gamma knife surgery similar to those of fractionated radiotherapy. Gamma knife surgery may produce better results with conventional radiotherapy in the treatment of pituitary adenoma produced by endocrinopathies. Gamma knife surgery seems to be safer than fractionated radiotherapy in terms of complication. General management. Pituitary adenoma management is complex and is dictated by size, symptoms, character of tumor. Treatment options require multiple modalities including surgery, radiotherapy, and medical management. General management, the multidisciplinary approach goals is to define the tumor extent, evaluate hormonal activity, remove tumor mass, control hypersecretion, and correct endocrine deficiencies. In the macroadenomas, transsphenoidal surgery or radiotherapy should be done. Macroadenomas, initial surgery with post-op radiotherapy, medical management, bromocriptine should be given, and somatostatin should be given. The treatment algorithm, the pre-treatment with MRI close to chiasma, no surgery, external beam radiotherapy, SRS, and gamma knife, visual field testing. If it is close to chiasma, visual testing. If there is deficit, yes surgery, no surgery or external beam radiotherapy. Complication that could happen is hypopituitarism, vision loss, carcinogenesis, radiation necrosis, and cerebral infarction. TSH producing pituitary adenomas are usually macroadenomas at the time of presentation due to delay in diagnosis. A diffuse goiter can be present up to 80% of the patients. Visual field defect, menstrual disturbances, and galactorrhea can happen. There could be thyrotoxic symptoms, and thyrotropin secreting tumors can be associated with secretion of growth hormone. Thyroid hormones circulate bound to the carrier protein, thyroxine binding globulin, TGB, albumin, prealbumin. Elevated thyroid binding globulin can be drug induced, oral contraceptive pill, tamoxifen, or due to pregnancy and infections. Disease like active hepatitis, this can result in the high levels of the total thyroid hormone, but determining free thyroid hormones can rule out the cause of the elevated T4. The most definitive treatment for the patient with TSH secreting pituitary adenomas is transsphenoidal resection of the tumor. The tumor is not very poorly, as only 1/3 of the patient are cured and 1/3 may show improvement and 1/3 may show no change. Pituitary adenomas, pituitary radiation alone or in conjunction with pituitary surgery has not been found useful. Octreotide is a somatostatin analog with a effective in most patients, but most of these patients has already undergone surgery. Slow-release formulation of somatostatin analog lanreotide improves the hyperthyroid symptoms but has not shown to reduce the size of tumor. Antithyroid drugs should be avoided as they may increase the size of the tumor due to suppression of the thyroid hormone. Challenges to the clinicians are to distinguish between the thyrotropin secreting adenomas and resistance to the thyroid hormone. Once raised, free thyroid hormones with non-suppressed TSH can be confirmed. Thank you.